Drugs that influence the renin-angiotensin-aldosterone system are one of those very important classes of drugs, especially for serious conditions like heart failure, hypertension, myocardial infarction, and even renal conditions, and in clients with diabetes mellitus. Today, we are going to have a review of one of the classes of those drugs called the ACE inhibitors. Hello, welcome to my channel. My name is Judith All Saints Appeal. I am a registered nurse from Uganda, and welcome to Pharmacology and Facts for Nurses. On this channel, we talk everything about drugs. We want to break down the knowledge about drugs into very simple to understand concepts that makes your life easy. I am as well an NCLEX tutor with NCLEX Review Series, a company in Uganda that supports nurses in their NCLEX journey as they work towards getting or obtaining a license to practice in the United States as a registered nurse and in any other jurisdiction that requires NCLEX for their licensure. So today we are going to have a review of ACE inhibitors. Every nurse needs to have quick facts about ACE inhibitors such that when you're asked, you're able to articulate them very fast. Okay? So in terms of our outline, we are going to look at the examples, mechanism of action, indications, adverse effects, interactions, contraindications, and then we'll look at the nursing implications or the nursing considerations. And without wasting much time, we will start right away with our examples. Which are these drugs that are called ACE inhibitors? ACE inhibitors are those drugs whose name end in the suffix "pril." Lisinopril, enalapril, captopril, benzapril, quinapril, etc. The prils. Those are ACE inhibitors. So if you get a question and they're just asking you about a particular drug, and that drug's name ends in that suffix "pril," the easiest way for you to think about the quick facts about that drug is first to take it back to its class, which is the class of ACE inhibitors. And usually, drugs are mainly classified according to how they work. So just by the name of this class, ACE inhibitors, you'll be able to predict how that drug works. You only need to know what ACE is. So that brings us to the mechanism of action. So how do the ACE inhibitors work? So like their name suggests, they are going to inhibit the activity of ACE, okay? Or they are going to block the activity of angiotensin converting enzyme. And then because that is inhibited, we will not be able to convert angiotensin 1 to angiotensin 2. And yet, usually angiotensin 2 plays a very important role in the body to maintain vascular tone and fluid balance. However, in this case, because we are blocking it for beneficial reasons, then we will not be able to form adequate amounts of angiotensin 2. And if that happens, then we are going to look at what resultant effect would be here. Now, usually, angiotensin 2's effect on blood vessels is to cause vasoconstriction. Okay? Angiotensin 2 causes vasoconstriction. But now, if we block that, then we are going to end up with a vasodilation. So vessels are going to be dilated. So we shall have a vasodilation. And then because we have a vasodilation, the vessels lumen are quite wider. Blood is going to flow through the vessels with less resistance. So we are going to have reduced systemic vascular resistance. If there's less resistance within the vessels, blood will also flow through less pressure. And this is happening in both veins and also arteries. Okay? So what are we going to see? We're going to see that we will have, at the end of the day, we will have a reduction in preload. Okay, and we might also, or we will also have a reduction in afterload. Preload is the amount of blood that returns to the heart from the body. Afterload is the pressure against which the left ventricle has to pump to push blood to the aorta and then to the rest of the body. Okay, now if we have increased preload, it means that a lot of blood is flowing back into the heart, so the heart is put under a lot of demand to push that blood through its chambers to the rest of the body. And if we have sustained increase in preload, that can start to cause changes in the heart that can be detrimental because it can bring about a cardiac remodeling. The same thing can also be happening within the vessels when blood is flowing through vessels with sustained pressure or with increased pressure. Then the vessels are going to start dilating and then hypertrophying, and that remodeling will start. Then also, if the afterload is so high, it's going to affect the left ventricle because the pressure is so much, the left ventricle has to pump so hard to offset that pressure, which can also be detrimental to it. So drugs that inhibit ACE and therefore inhibit the production of angiotensin 2 are going to cause vasodilation, reduce systemic vascular resistance, reduce blood pressure. And that then helps, for example, in a client with hypertension, but also because it's reducing the vascular and cardiac remodeling, then we are also going to have a reduction in cardiac remodeling, which is very beneficial in heart failure and myocardial infarction. Now, another effect of angiotensin 2 is to stimulate the pituitary gland to release antidiuretic hormone. But now in this case, we will have, let me use my blue. This is quite faint. So we will have a reduction in antidiuretic hormone. Remember, ADH is also a vasoconstrictor because now we are having less amount. We are also going to have vasodilation here. Then the function of ADH is to reabsorb water from the later parts of the distal convoluted tubule and the collecting ducts. Because we are blocking this, we are also going to have a reduction in water reabsorption, which is going to reduce the blood volume. Okay, when we have a reduced blood volume, our preload also goes down. The demand on the heart is reduced. Blood also does not flow through the vessels with that much pressure. Then, the third effect of angiotensin 2 is felt on the adrenal gland. And in the adrenal gland, angiotensin 2 is going to cause production of aldosterone. Now, because we are blocking it, we are going to have no aldosterone or very little aldosterone. So if this is the case, we are going to have a reduction in salt and water reabsorption. Okay, we have a reduced salt and water reabsorption. We also are going to retain potassium. Remember, aldosterone leads to reabsorption of sodium and water from the DCT and the collecting ducts and loss of potassium. But now because we are blocking it, we are going to retain potassium and then we lose sodium and water. So we are going to have an increase in K. Okay, so what you're trying to see here then is that we are having vessels that are dilated, we're having a reduction in fluid volume or in blood volume. Okay, because here if we are losing salt and water, that is what this is causing a natriuresis, where we are losing salt and water in urine. So the blood volume really gets depressed, and that is very beneficial. If the blood volume is little, again, it translates to a reduced preload. The amount of blood that is going back to the heart will be low. So we are not going to put the heart under a lot of work. and that can then, in essence, slow down. Okay, so we are going to slow down CVS remodeling. Okay, CVS remodeling are those structural changes that we see happening within the vessels and in the heart chambers as they accommodate the increased demands, the increased load that has been subjected to them. And those changes are detrimental to the heart. They're detrimental to the vessels. They can fuel hypertension. They can worsen heart failure. They can speed up the progression of disease. And that's why then we find it very useful to block ACE and therefore to reduce the amount of angiotensin 2 that is being produced so that we can reverse the effects of angiotensin 2. So that's the mechanism of ACE inhibitors. Now, I want to also introduce another fact about the mechanisms of ACE inhibitors. Okay, now this enzyme ACE is an enzyme that does not have only this role of converting angiotensin 1 to angiotensin 2. ACE also degrades, okay? It's going to degrade some vasodilators in the body, especially bradykinin and substance P. Okay, so angiotensin converting enzyme degrades or breaks down bradykinin and substance P. Now, these are vasodilators. If we block ACE, it means we are also going to block degradation of bradykinin and substance P. So their levels are going to increase in blood and they're going to produce a beneficial effect, which is vasodilation. So they're going to cause vasodilation, which is very good, okay? Which still adds on to the beneficial effects of these ACE inhibitors. But at some point, I'm also going to explain to you how these can bring about some of the side effects of ACE inhibitors. Our third part of this discussion is going to look at the indications. For which conditions do we use the ACE inhibitors? So the first condition would be hypertension. And really, it's coming from here. See, we are having a vasodilation, which reduces resistance within the vessels and then blood flows with less pressure. But also the fact that we are reducing on the fluid volume. It's also going to reduce the pressure. So these drugs are very beneficial in hypertensive patients, but as well because it also reduces vessel remodeling. Okay, so that would be very important in hypertension. Then these drugs are also very useful in heart failure. Okay, again, we've seen the demand that is going to be subjected on the heart when volume is increased, when preload is increased, when afterload is increased, which can be detrimental to the left ventricle. The left ventricle can start dilating, hypertrophying, because the cells are put under increased demand. Cells are rapidly dividing. There are fibrotic changes that are happening. So because of those changes that are taking place in the heart chambers, they can fuel heart failure. So when we block ACE, we are going to slow down the remodeling of the heart. In other words, we are going to slow down the progression of the disease, which also brings us to left ventricular dysfunction. Patients with left ventricular dysfunction, even in the absence of heart failure, benefit from ACE inhibitors because there's going to be a slowing down of cardiac remodeling. So the heart chambers tend to stay healthier for a lot longer. Then the fourth indication are those clients with myocardial infarction. Post-myocardial infarction, ACE inhibitors also inhibit myocardial hypertrophy, which can still prolong the life of the heart. Then, in patients with diabetes mellitus, now the effect of angiotensin 2 on the efferent arterioles in the nephron constricts the efferent arterioles so that instead of blood flowing away from the glomerulus, blood backs up into the glomerulus, and that is going to increase the pressure with which filtration is happening, which also has an effect of increasing filtration rates. But that increase in pressure can be detrimental to the glomerulus. Okay, it can be detrimental to the nephron, and it's quite worse in diabetics. Remember, diabetes mellitus is one of those conditions that easily leads to kidney damage. So if we are having the RAAS system exaggerated in this case, it can fuel a diabetic nephropathy. So these drugs are usually the drugs of choice in clients who are diabetic. And because of the effects of drugs that inhibit the renin-angiotensin effects on cardiac remodeling, these drugs are considered first choice drugs in clients with hypertension and with heart failure. Okay, it really ties down to the cardiac remodeling and CVS remodeling effect. Let's look at the adverse effects and the side effects of the ACE inhibitors. So usually, if you understand how drugs work, it will also be easy for you to predict some of the side and adverse effects that these drugs may produce. For example, since we talked about ACE inhibitors as being antihypertensive, they reduce blood pressure, so they're going to cause hypotension. And this hypotension is very significant with the first dose of the drug. So usually there is a first dose hypotensive effect associated with ACE inhibitors. And this will be more seen in clients who are already on other antihypertensives because there's going to be that additive effect. It's also going to be seen among clients who have low salt level or low sodium level, and then even in some clients with heart failure. So hypotension is one of those, and that usually puts a client at risk for orthostatic hypotension, which is a safety thing in the NCLEX exam. If the blood pressure is low, we might as well complain about dizziness and fatigue. Then clients also do complain about headache. Tachycardia would be more like a compensatory mechanism for hypertension. So your heart tends to pump faster in trying to pay up or compensate for that reduction in blood pressure. Then a class-specific side effect, okay, which is also considered a class effect. A class effect would mean that there is a side effect or an effect that is produced by all members of the class of drugs. So, for example, if captopril causes cough, lisinopril will cause cough, quinapril will cause cough. So that's a class effect. That's because of the similarities in which these drugs work. We already mentioned earlier that ACE inhibitors inhibit the degradation of bradykinin and substance P, which would be very beneficial because it's going to cause relaxation of the blood vessels or vasodilation. However, on the other side, the accumulation of bradykinin in the respiratory system is going to cause a bronchohyperresponsiveness. So it's going to trigger a cough. This cough is usually described as being dry, itchy, and irritating to the throat. If a client complains about the cough, the dose of the medication may be reduced or the drug may be switched to another class that does not cause that. Maybe the patient would be switched to an angiotensin receptor blocker, the statins, maybe candesartan or losartan, okay? Yeah, so cough is a very common thing. It is seen with ACE inhibitors, not the other drugs that influence the RAAS. It's ACE inhibitors because ACE inhibitors are the ones that block ACE and therefore allow for bradykinin to accumulate. Then, of course, these drugs cause hyperkalemia. Like we've seen, if you don't have angiotensin 2, we will not have aldosterone, and a lack of aldosterone is going to mean that we retain potassium in the body while losing sodium and water. So hyperkalemia, very common thing for the NCLEX lady. These drugs might also cause acute renal failure, especially in patients who might have bilateral renal stenosis. So usually blood flow to the kidney is going to be compromised, and then you find that we end up with a renal failure. Then another thing that is a class side effect is angioedema, swelling of the vessels because of the accumulation of bradykinin. Remember, bradykinin is a vasodilator. So we are going to have swelling of vessels around the nose, the throat, the mouth, the lips, the tongue, the larynx. The patient actually complains that they feel there's a swelling sensation. Angioedema puts one at a risk for an airway compromise. So it is a very serious adverse effect. It's one of the fatal adverse effects if we don't deal with immediately. And yet, if identified early and the drug is stopped, the effects also tend to wear off within a short time. So angioedema is as well class-specific side effects in that if a client experiences angioedema from lisinopril, then you cannot give any of the other prils because those are also going to trigger an angioedema. There is almost a 4.5 times risk of angioedema in African Americans compared to their Caucasian counterparts. Okay, so when you're taking care of clients, you look at the African Americans who are on ACE inhibitors, you need to watch out for this because of the increased risk among that population. Then also ACE inhibitors particularly tend to cause test alterations. Some clients may say they actually have a loss of taste. So that's also very common. Skin rash, more like hypersensitivity. Then they also do cause blood dyscrasias like neutropenia. And for you to tell that the client might be neutropenic, they will complain of a sore throat. They may have a fever. Thrombocytopenia, which may predispose to bruising, petechial hemorrhages or bleeding. They are hepatotoxic. Then they are teratogenic. For the NCLEX, there are a number of classes of medications that you need to know that are contraindicated in pregnancy. Drugs that influence the RAAS are one of those classes. So ACE inhibitors, angiotensin receptor blockers, direct renin inhibitors will not be given in clients who are pregnant because these drugs can lead to renal problems, renal pathology in the neonates because of a reduction in blood flow to them. Let's now move on to the interactions, the drug-drug interactions. An interaction occurs when more than one drug is being taken at the same time or concurrently, and one drug influences either the pharmacokinetics or pharmacodynamics of the other. So let's look at the common drug-to-drug interactions that occur with ACE inhibitors. The first will be the NSAIDs. When you give NSAIDs together with ACE inhibitors, NSAIDs are going to reduce the response to ACE inhibitors, the blood pressure reducing effects of ACE inhibitors. How does this happen? NSAIDs, non-steroidal anti-inflammatory drugs, common class of drugs that we know, work by reducing or blocking. They work by blocking the production of prostaglandins. There are different kinds of prostaglandins and they play different roles in the body. But one of the effects of prostaglandins, a certain kind of prostaglandin called the prostacyclin, is to dilate vessels. So if NSAIDs block prostaglandins and then we are giving our ACE inhibitors that are supposed to dilate the vessels, okay? This effect of the NSAIDs is going to reduce the effect of the ACE inhibitors. So be very careful when the client is on ACE inhibitors and then probably they've also been prescribed an NSAID. Then we have the antacids. Now, antacids generally as a class of drugs are usually those drugs that we don't want to give with any other drug. In fact, for your NCLEX examination, if you get a question where they're asking about interactions between medications and you find antacids, just know that antacids should not be given with other drugs because of various different ways in which they cause interactions with those drugs. So when we look at ACE inhibitors and antacids, antacids are going to reduce the bioavailability of ACE inhibitors. So first of all, what is bioavailability? Bioavailability is the fraction of drug that reaches the systemic or general circulation unchanged, especially when we take those drugs orally. So now when you give ACE inhibitors together with antacids, antacids have the potential of binding the ACE inhibitors, which reduces the extent of absorption. Extent is how much of the drug gets absorbed into the bloodstream, and that then can also reduce how much of the drug is going to get into the general circulation and into the site of activity. So that's another interaction. Then, if we give ACE inhibitors, which are already antihypertensives, concurrently with other antihypertensives, we are going to get additive hypotension, profound hypotension because of the additive interactive effects. Then we have already seen that these drugs cause hyperkalemia. So again, if you give the drugs with other drugs that also raise potassium level, like potassium sparing diuretics or potassium supplements, okay, these are going to aggravate the hyperkalemia because they're just going to exacerbate the hyperkalemic effects of the ACE inhibitors. So we don't want to give those drugs concurrently. Examples of potassium sparing diuretics would be such a drug like spironolactone or amiloride or triamterene, etc. Then ACE inhibitors increase the levels of lithium and the levels of digoxin. So we can end up with lithium toxicity. We may also end up with digoxin toxicity. So these are some of the common interactions or common drugs that interact with ACE inhibitors that, especially for those who are reading for the NCLEX examination, you might get a question like that where maybe a hypertensive client has been prescribed captopril. Which of the following drugs would the nurse question? Then maybe one of these is among those drugs. All right. So you just want to look out for any of the drugs you know that might cause interactions with ACE inhibitors, and that is what you would question. We question those things that we think are not right for our patient. Maybe they're going to put the patient at risk. The drug is going to cause interactions. The drug is going to cause an adverse effect. The patient maybe has a contraindication. So we question that, okay? Yeah. Then, when we come to decide what are the contraindications for ACE inhibitors, of course, allergy would be one of them. And most notably, if a patient already had a previous experience of angioedema, you don't want again to put them on ACE inhibitors. No prill whatsoever. Either another antihypertensive will be prescribed for them or another drug that influences the RAAS, maybe the ARBs or a renin, a direct renin inhibitor, but not an ACE inhibitor because of their class effects. Then hyperkalemia is one of the adverse effects of this drug. So if a client is already on the upper limit for potassium level, that is 5, or they're having high potassium levels, we don't want again to subject them to drugs that are going to increase the potassium levels. Otherwise, hyperkalemia is going to bring about dysrhythmia. So you will again have something new to deal with, not safe for your patients. ACE inhibitors are teratogenic, especially in the second and third trimesters. So usually we just say do not give to pregnant mothers. So you may first of all need to ascertain whether your mother is pregnant, or if it's a female client, they're pregnant, so that this drug is not given to them. Or if they're not pregnant, they should be able to report in case they get pregnant, because we will need to stop the medication. Otherwise, the fetus might have renal problems. Also contraindicated in lactation and in children. Then, we already saw that ACE inhibitors tend to cause acute renal failure in clients with bilateral renal artery stenosis. So if this is already diagnosed in a client, you again do not want to put them on ACE inhibitors. So looking at this, for NCLEX takers out there, the NCLEX lady does not really bring things from out of the blue, etc. They are the common things. When we come to the side effects or the adverse effects of ACE inhibitors, you need to know at least, okay, there are some common ones, hypotension, cough, hyperkalemia, angioedema, taste alterations, and then this neutropenia. Those are very common things that you need to know. Then you can add on these others in there. Of course, some of these you're just going to reason them out of how the drug works. If the drug reduces blood pressure, if you're hypotensive, you're likely to be fatigued and dizzy. Okay, tachycardia is likely to come, the headache. You're going to see that. So note these. Okay. Also note that cough is only seen with ACE inhibitors. Cough will not be seen with angiotensin receptor blockers or renin inhibitors. Why? Because it is only an ACE inhibitor that is going to increase bradykinin levels. Okay, note the others. Angioedema, although angioedema may be also seen with clients on ARBs or direct renin inhibitors, it is more commonly seen with ACE inhibitors. You may get a question where maybe they're saying your hypertensive client was prescribed lisinopril, okay? Which of the following adverse effects would you attend to first? Which of the following adverse effects would you attend to first? So you want to prioritize who you're going to see first. Remember, the person you're going to see first is the one who is very unstable, the one whom if you don't do anything, something wrong is likely to happen. So let's say we are having dizziness, okay? We are having cough, we are having angioedema, and we are having taste alterations. So dizziness, sorry, let me mark this. Dizziness, cough, we have angioedema and taste alterations. Which client will you see first? So your client who is likely to deteriorate if you don't see them immediately or if you don't do anything immediately is a client with an airway problem. And angioedema presents an airway risk, airway compromise risk. So this is a client that you see first, okay? So when you find a question where they're talking about ACE inhibitors and there is something that is drawing you towards angioedema. It can be that the client is complaining of neck swelling or swelling of the tongue or, something related to that. Just point it to angioedema. Angioedema has a potential for compromising the airway, so that becomes your priority client. I hope that is clear. After learning about all those facts about the ACE inhibitors, let's now look at the nursing considerations and what teaching points that we can prepare for our clients. All right, so of course, what we are going to consider is we shall assess and monitor the vital signs of our patients because these drugs are drugs that are going to alter blood pressure. So monitoring blood pressure, the pulse rate and respiratory rate will be very key in our management of these clients or in our nursing interventions. And while we assess and monitor the vital signs, of course, we'll need to begin with the baseline vitals so that it can give us a comparison status for when we monitor the after vital signs when we have already begun our medications. Then also we've seen what these drugs do to the respiratory system, so we can as well monitor the respiratory status, looking at the respiratory rate. Is there cough? Is a patient complaining of that swelling along the neck area or swelling in the tongue, the mouth area? So we also do assess and monitor for that. Then, every time we use drugs, we need to assess for whether the drug is effective or whether they are not, and also if they are producing unwanted effects. If you are monitoring for therapeutic effects, every time they ask you what parameter you would use to monitor for therapeutic effects, look at why the drug was given. So if our drug was given for hypertension to bring down pressure, then we are going to monitor the blood pressure and we will report on a reduction in blood pressure to either our target or goal blood pressure. So let's monitor for therapeutic effects, and then we also monitor for adverse effects, for side effects. Is the patient complaining of dizziness? Are they complaining of fatigue? Is there headache? Are we having, of course, tachycardia? So you ask around for that. Ask for taste alterations. Ask for presence of cough, angioedema, etc. Then we are also going to monitor our serum electrolytes, especially serum potassium, because we saw that these drugs are going to increase potassium levels. Also, because they may be harmful to the kidney. We saw in that example of a client with bilateral renal artery stenosis, which can lead to acute kidney injury. So monitoring for kidney status or function status, blood urea, nitrogen, and creatinine. We shall monitor a complete blood count plus other indicators of infection, for example, sore throat and fever, and then ask the patient about any test alterations or if they find that they've lost taste. Monitor for angioedema, because usually angioedema is a fatal adverse effect if we do not intervene in a timely manner, because there's going to be swelling around the neck area, the mouth area, the tongue, the mouth, the larynx, okay? The area around this place is going to be swollen, and that has an effect of compromising the airway. So because of airway compromise, we need to be very careful about this. So we monitor for it, and if we get a positive response of angioedema from the patient, then we have to withhold the medication, okay, and notify the healthcare provider why you have withheld. Usually these effects should go off in a short time. Then of course, monitor for bruising, petechial hemorrhages, or even any bleeding itself. Then when it comes to client teaching, because these drugs cause hypotension and orthostatic hypotension. Orthostatic hypotension is a drop in blood pressure when we change position to an upright one. So because of that, you want to advise the client or teach the client to get up slowly, let's say from a sitting or sleeping position to standing. Actually, getting up from a sitting or sleeping position helps for the hemodynamics to stabilize. Otherwise, if they get up suddenly, then their pressure is also going to drop suddenly. They can fall, and that can cause injury to the client. Also, inform them about cough, about taste alterations. One of the reasons why we teach clients is so that they know what to expect. Sometimes some effects they're going to get once they start taking medications may make them want to stop the medications. But when we educate them well, we explain to them that this is not dangerous, or we tell them what to do in case that thing occurs, then they're going to take the medications appropriately. So informing them about a cough, And if they feel that the cough is irritating, then they should report to the healthcare provider. In that way, they will be evaluated. Maybe the dose will be reduced, or they're going to switch to another drug that does not cause cough. Also, ask about taste alterations, and then teach them to avoid potassium supplements and even foods that are high in potassium, because we don't want to exacerbate the hyperkalemia. Instruct them in how to take blood pressure, because when they go home, they also still need to monitor their blood pressure so that they don't run the risk of getting hypotensive or severely hypotensive. Then teach them what things to report to the healthcare provider, the adverse effects, angioedema, cough itself. Teach them to report any sore throat or fever, any bruising, hemorrhages, etc. So that in that way we keep our clients safe. So that has been a review about the ACE inhibitors, one of the first-line drugs when it comes to managing hypertension and heart failure, and some of other conditions that are influenced by the RAAS system. I thank you for listening. For this and much more, I'd like to request you to subscribe to my channel, like this video, and also share with your friends and share it to a wider audience so that everyone may benefit. So apart from the farm knowledge that I give on this platform, I am also an NCLEX tutor, and I work with NCLEX Review Series, a company in Uganda that supports nurses in their NCLEX journey as they work towards acquiring a US RN licensure. And on that note, I would also like to encourage you to subscribe with NCLEX Review Series or NRS. I am going to link the contacts here so that you may be able to be supported in case you'd like to sign up with us. Come, let us support you. Also subscribe to this channel because you're going to get a lot of good pharmacological content. For those who are in nursing school, the same thing. Thank you, and I wish you all the best in your endeavors.